So I am pinch hitting today for both this one and the focal one for Katsuro Shinohara, who's out of town, and Han Win, who's also out of country, unfortunately. So, so how do we biopsy? When do we biopsy? Why do we biopsy? You know, and that last question is really important, follows directly from the first talk. The goal of doing a prostate biopsy is to find clinically significant prostate cancer. We typically have defined clinically significant as anything grade group 2 or higher. But again, a lot of the grade group 2s, we don't necessarily need to rush in and treat, but generally speaking, we at least want to know that they are there, as opposed to the grade group 1, which we're more or less happy not knowing about. And just to emphasize the point I made in the first one, grade group 1, we can almost think about as a normal feature of male aging. If you make it to your 70s as a black man in the US, your 80s as a white man, 50% of all men will have these cells under the microscope that we have historically called cancer, but have zero capacity to spread or cause any clinical symptoms. And we are trying really hard not to find these things. We have more biomarker tests than we know what to do with at this point for every clinical decision, from do we check a PSA, do we do a biopsy, do we repeat a biopsy when it's been negative, how do we treat? We've got a huge number of tests now to try to help us predict who is going to have a grade group 2 or higher. And if one of these tests is negative, it means either there's nothing there or there's a grade group 1. In either case, we don't do the biopsy because we are trying not to find grade group 1. There's a large growing pool of us that are starting to say we shouldn't even use the word cancer because it doesn't behave like a cancer. It doesn't have any capacity to cause problems. We're happy to not find it. And this is all working. In the early days of the Capture registry, which Peter Carroll started here in the 90s, this is the first registry looking at capturing community practice for urology. In prostate cancer, 50% of the cancers were low grade, low risk at time of diagnosis. This is now in that AUA registry under 20%. In the UK, where you basically can't get a biopsy without an MRI finding, it's down to 7%. So we are really relegating grade group 1 to this idea of being an incidentaloma. It's something that we find accidentally in the course of chasing and looking for real cancer. So we have a huge number of options here. There are blood tests, urine tests, imaging tests like MRI. Maybe PET scan will eventually have a role here. The ones in bold are the ones that we've used most frequently in our practice here. But there are many options. And almost universally now, we're going to recommend some test along these lines before making a biopsy decision, unless the PSA is really, really high, like over 50. MRI itself is interesting as a potential secondary screening tool here. The problem with MRI is not the test, it's the way we interpret it with the PIRAD system. If any of us had a prostate MRI, you spend half an hour on the magnet listening to the clanging, the machine collects an incredible amount of data. We then sort of dumb that down into a grayscale picture for the human radiologist to look at, and they say, well, it's a 4. And then we dichotomize that to make a clinical decision about do we go forward with biopsy. So we are losing a huge amount of information from the magnet to the clinical decision, and this is exactly where AI is going to have its role. This is coming very, very hard and fast for prostate MR. There are a few dozen tools already approved by the FDA here. There's an open source initiative called PyChi, which is revolutionizing how we use MRI data. So today, I don't necessarily trust MR as a decision-making test, but we're heading in that direction very quickly. So there's many different pathways here. In many parts of the world where MRI is a lot less expensive than here, MR is the secondary test, admitting its drawbacks. And if the MR is positive, you do a biopsy. We can do the same thing with one of those liquid blood tests or urine tests, all of which are about 95% accurate in ruling out high-grade cancer. This is often what we do here. So we'll get a biomarker to decide who needs to go forward, and then get an MRI, not to decide whether to do the biopsy, but to help guide the biopsy. And that's a different point. And it's very important that we have imaging to help guide the biopsy. Some folks will flip it. They'll get an MRI first and only use a blood or urine test if the MRI is equivocal, or maybe the biopsy was negative despite the MRI lesion. You can spend all the money and do all the things up front and try to integrate all this to make a decision. Any of these is reasonable and defensible with the literature. Again, the one that we do most often here, I think, is the middle path. But even here, we will individualize things. If I see a man who's got a lot of voiding symptoms, we think there's a lot of BPH at play, I may well start with an MRI because we'll get the size of the prostate as well as the ability to look for lesions. So, again, I don't really rely on imaging tests to make a decision about whether to do a biopsy, but it's essential that we have high-quality imaging to guide the biopsy. And that can be a number of modalities. Katsuro Shinohara here has led a world-class ultrasound-guided biopsy program for literally decades. And the reality is we here can see most of the higher grade lesions very well on a standard transrectal ultrasound. MRI is getting better all the time. And this is an example of a restricted spectrum imaging scan, which we are gradually implementing here, which gives us, in addition to the standard images, these really nice sort of heat maps of where the cancer is likely to be. We're also struggling a little bit for logistical reasons to get our micro-ultrasound program going, but micro-ultrasound was studied in a randomized trial versus MRI, published last year in JAMA, and is pretty much as good as MR, and is often easier from a logistical standpoint because you don't need to make 2 trips down to San Francisco. So having a test like this, or sometimes more than one of these tests, really helps us do a better job choosing exactly where to go with the biopsy needles. Now, prostate cancer always has to have fun controversies. It's what keeps us all excited about coming to work, along with taking care of patients on a day-to-day basis. One of the big controversies in the last couple of years has been transrectal versus transperineal biopsy. And like many controversies in prostate cancer, there's a little bit more heat than light here, I think. Biopsies classically were done almost exclusively transrectally. Either way, we have a probe in the rectum to generate the images, and transrectal biopsy goes through that probe directly into the prostate. Transperineal biopsy, we go through the skin underneath the scrotum to reach the prostate this way. And there's been a lot of discussion, a lot of hype around whether one is better or another. In the past 2 years, we've had 4 randomized clinical trials published, and there was a recent meta-analysis, which is a statistical way of merging the data from these different trials. And what you want to really focus on is the summary line here. So for a couple of different outcomes that they looked at, we can summarize these 4 different trials. And for example, the question of whether one detects cancer better than the other, the answer is no. It makes absolutely no difference. The one line here is where there is absolutely no benefit for one versus the other, and this is exactly where you see the summary. We can find the cancer perfectly well with either approach. What about infection rates? This is where there's been a lot of hype. Why would you go through the rectum when you don't have to? Again, in terms of overall infections, absolutely no difference. In terms of severe infections, these are sepsis rates. These are much less common, and there is almost a statistically significant difference here favoring the transperineal over the transrectal, but the event rates here are very small. This is 13 versus 6 events out of the 1,300 men who were in each arm of this trial. So the severe infection rates we usually quote as 1%, and that's really about right. And the trade-off is transperineal is substantially more uncomfortable. And this is true despite the fact that we do a very good local anesthetic here. Some of my colleagues that are doing a lot of transperineal biopsies do them all in the operating room because the discomfort is substantially more than with TR. So, in terms of when, who and how, the goal of the biopsy, why we do a biopsy, again, is not to find prostate cancer. It's to find life-threatening prostate cancer, and it's really important to know that going in. We now have open records. Everybody can see their pathology reports early, and we really try to warn everybody, when you get that pathology report, it's not a yes-no, it's a yes-no sort of. If we see a high-grade cancer, we're going to have the conversation about management. If it's benign, great. If it's grade group 1, which again, it's arguable whether we should even use the word carcinoma on that report, these are ones that we do not need to get too excited about, and we try to get that information out even before the biopsy. We will use secondary testing for almost everybody with elevated PSA. TR and TP are both perfectly reasonable approaches here. There's sometimes anatomic reasons we want to focus on one versus the other, but the trade-offs here are honestly relatively subtle. And imaging is getting better all the time. There is a long-term goal that we can diagnose the cancer with an imaging test, just like we would kidney cancer, and avoid at least the repeat biopsies we do in active surveillance, maybe even the diagnostic biopsy. And I think we will get there with better imaging modalities plus AI eventually. So, thank you.